We have a great session coming up this afternoon. It's about what do we do for the next pandemic? What have we done? What have we learned? And what do we do? So our speakers are going to stay on task. They have about 8 minutes per talk, and I'll just hook them off the stage if they're late. But the goal is really, we've got some really good speakers here, and we want to have good panel discussion and interaction. So we're going to get started. Our first speaker is Rodrigo Diaz out of South America, and they had lots of challenges, as we know. And he's become a good friend of mine over the years with ELSO. So Rodrigo, off to you, and then we'll keep moving through the speakers.
Sorry about the lectures, about the slides, because I did them in keynotes and now they're in PowerPoint. That's a big deal. But anyway, I'll go. So, I'm Rodrigo Diaz from Chile, Santiago, Chile, the capital. No disclosure about this subject, and we're going to go through the conditions and lessons learned after ECMO COVID care in Chile. Chile is a South American country with 18 million inhabitants, a mixed public and private health system, but during pandemic it was fused just in one because of the pandemic. We have a territory of 4,200 kilometers, very long and difficult geography, very mountainous land. And we do ECMO care on a regular basis since early 2000s. As you can see, very narrow, but very long. What about the background of the pandemic? Before pandemic and ECMO development, we were at this point. The existence of ECMO centers with established programs, and some others that not, national guidelines, development of regional centers, anti-cardiopulmonary syndrome, and a very young target population move us to think on ECMO as a society many years before pandemic. That was good. And our medical registry of devices is simple or non-existent. And believe me, that's an advantage. In 2013, we had established ECMO in antivirus syndrome management algorithm. And in 2015, Chilean National Society of Critical Care and the government developed guidelines for VV and VA ECMO. In the case of ANTA, the patient should be transferred to an ECMO-capable center, independent of the clinical status. And this is the change observed in the busiest ANTA center in Chile before and after ECMO incorporation, with full training before and after they started the program. Actually, lethality is around 20% in antivirus syndrome, with an historic mortality of 35%. I'm pretty sure ECMO program has done something about it. Between 2015 and 2020, before pandemic, more ECMO centers were developed, especially in the south because of the antivirus again. Chile, of course, is not a high-income country, but for different reasons, we were doing 180 cases in 2016 and more than 280 in 2021. This is far of being an ECMO bed competencies team, but it's a substitute as an approach to ECMO capacities in different countries. I recollected this data at the beginning of the pandemic. And you see again, Chile is in an intermediate situation. What are the negative aspects before pandemic we have to face? Again, our gross domestic product is not the highest. A social breakdown in October 2019, just 6 months before pandemic, and believe me, it was a huge deal. And lots of hospitals doing ECMO, but with a low number and without a formal program. That was the breakdown, the social breakdown. It was quite a big thing. But if you look at the GDPs, Chile is not very high. The US, for example, nowadays has more than 60,000. Qatar is more than 100,000. Well, it's the biggest in the world. But some years ago, I looked into the number of patients being reported to ELSO, and I found there's a strong correlation between GDP per capita and ECMO cases reported to ELSO. Very strange. And as you can see, Latin America, the median number of patients per center per year is the lowest, and it keeps being that way. So, back again to Chile. Before first wave, in February 2020, the Ministry of Health collected called for a task force in conjunction with the Critical Care Society. And we went there. And they put us on the table that they were willing to do ECMO for COVID cases, even we didn't have any at that time. We will have to propose standards, organization of the network, clinical guidelines, and measure the results. This is an example. We published and we did several web lectures in ARDS management and in ARDS with ECMO in conjunction with the government and the Critical Chilean Society. In 2020, we made a cadastre of ECMO availability, and we'll have a constant information of these beds within the commission 24/7. Usually it was more close to 32 beds because it's not only the ECMO, it's the critical care staff. But we decided at the beginning of 2020 to increase the number of pumps available in the centers that already had ECMO programs. So, the calendar, March 3rd, 2020. The first case was in Santiago, the busiest city? Nope, it was in Talca. What about Talca? Talca is like our Chilean triangle of Bermudas. Every bad thing starts there. Incredible. Whatever you think. So this is the face of the Secretary of Health at that moment, and he will say Talca again. Talca, as a matter of fact, was the 2010 earthquake epicenter. So you see a correlation there. We established an allocation process together with the Intensive Care Allocation Office of the Ministry, very similar to what was done in other countries like Japan or UK or other countries, with a system that will score the patient conditions and the national capacity of critical care beds. So the threshold will change depending on how busy the critical care beds were at that moment. And we moved patients in a network more than a spoken hub, a point-to-point network. We will move patients from the south to Santiago and Santiago to the south, wherever there was an available bed with ECMO capacity. We had two surges, one in 2020 and the next one in 2021. As you can see, the surges resulted in more ECMO cases too. Fortunately, after these two surges, has been everything more calmed down, and we usually don't have more than 10% of critical care occupancy by COVID patients. That was the data of yesterday. We get the information every day, and 8% of the patients in critical care beds in Chile are COVID. My former center was the only one doing mobile ECMO at that time on a regular basis, but soon 3 more will do. They will do primary, secondary, and tertiary transfers. That's one of the examples where we're transferring a patient from other hospital to ours. Until now, we have 4.5 million cases of COVID. Remember, 18 million inhabitants, with a little bit more than 60,000 deaths reported. In this context, we could publish the total number of experience in the first surge. And we found that 1.2% of all the mechanical ventilation patients in Chile got into ECMO. We found a lot of complications, including hemorrhagic stroke, more than 12%. And intra-hospital infection was huge. Survival at that time for the first surge was 61%. But after the first surge, we realized the same things than many other centers. Basically, COVID patients are not unusual ARDS patients connected to ECMO. They're very different. They're longer runs, they're more difficult, they have more infections, there are more variables than the usual ARDS patients. During the second surge, we had much more requirements. At your left, you're going to see that in orange, all the patients that were requiring ECMO, but we had to say no, or the patient simply was out of time, or the patients got better. We are looking at that data, and that has been the hard part of our second publication. Sorry for that, but this wanted to show that on the second surge, we had 180 patients and 94 in the first one. If we look at my former center, We had a 78% survival in the first search and 87 in the second. We had the patients filtered by the commission. It's not different from the others. But we had a lot of experience before doing ECMO, and we were a platinum center. But as you see, the patients will be as the patients were being triaged from the commission, they were very young. You can see 48 at the first search, 43 at the second. That's very, very young in comparison to other countries. Compare that to Germany, and it's crazy. I mean, it's completely different. 10 of these 68 patients were more than 60 days of ECMO. And of those 10 patients, 9 survived. 3 of them got into transplant. But a lot of patients with more than 100 days didn't need finally transplant. So it's a very difficult situation when you go up more than 2 months being supported. This is the data from Chile, comparing the first surge that we reported and the 2021 that we want to report, but we're stuck in that. And the death decreased a little bit, very different from other cases, very different from developed countries. Maybe because we triaged a lot and filtered a lot, because the ECMO beds were very scarce. A lot of mobile cases, and ICH decreased quite a few. I think we learned a lot of lessons regarding heparinization at the beginning and CO2 management at the beginning of the case. This is a typical patient in my unit. This was an ICU bed of 8 beds, and we will manage the patients this way. No Foley, moving them right after we cooled, and even sometimes without an intravenous line. And I think that was part of our success. We will try to move them very, very early. This is one of our transports. That's the way we do it. It was very uncomfortable with all the PPEs. And finally, we found a 39% mortality in the first wave, in the first surge, and 3-4 in the second. We decreased, but as I'm telling you, there are other variables because we did a lot of triage. The high incidence in the first wave of intracranial hemorrhage decreased, fortunately, and survival was better in the second wave. This is the photo you have in your red book. This is a photo of my former center. I personally, I didn't take the picture, but I took care of this patient. His name is Miguel Ormeño, and I asked him the permission to show this photo, and he was more than 100 days in the unit. He will know everybody. He was customized for a while, and so he even told me once that where was my backpack in the unit. So this guy was a lot of time in the unit, and this is his photo yesterday. So he's working again since 6 months ago, and he's doing great. So the lesson learned, 3 lessons. 1, egos can be beaten by a pandemic. You have to talk each other. Second, don't go for too much data in the analysis. That's why we're stuck in the second publication. And third, do not go to Talca. Thank you very much.
All right, our next speaker, Vince Pellegrino. I'm going to take these bottles down here. Vince comes out of Australia, and he's going to teach us something.
We'll see.
Hopefully.
She's putting pressure on me. Thank you all again. Thanks for sticking out the afternoon session. So it's an interesting story. COVID has lots of interesting elements. I'd like to tell you about our one. So in terms of disclosures this time, there are no financial disclosures, but and no research issues, but the clinical jobs I have are very pertinent to this. So half the time I run a statewide ECMO service rather than a hospital ECMO service. And so in Victoria, the state in which I come from, ECMO and ECMO CPR are provided by an ICU-based statewide service between designated centres that are all coordinated, and they're centrally governed to run. Now, as well is they're linked to both an operational database, so we know, minute by minute all the patients on and where they're up to, and an in-depth research database as well as that links with ELSO as well. So we have a lot of data from these patients. Now this to get this up and running took about 3 or 4 years, and many people worked to do it. And the reasons we wanted a statewide coordinated system rather than siloed services that were all trying to provide the same thing is because the reality in our part of the world is that ECMO is obviously a complex condition to run. It's not a straightforward condition, and there's quite low utilisation, so we would never exceed 150 cases per year, so having multiple centres providing it doesn't make a lot of sense, and it's quite a low tolerance service. If you make a mistake or get off track, it becomes very difficult, and it's obviously very resource intensive, so you need to know all that. And we don't have replication of clinical services across hospitals. Like everyone has trauma hospitals and burns hospitals and transplant services located to some hospitals, so we're used to it for that, but it's different for a resuscitation tool accepting that. And we know that the number of cases are escalating and the number of centres are both increasing, and we wanted to stay ahead of that trend as well. So in terms of providing ECMO, we think very much that it's not really a reproducible effect. It depends very much on local circumstances and local world, and this is a view that I have held for forever, and I ask you to share that if you like. And we know that you know, in the surgical world that volume outcomes exist, and there's a lot of literature to say that outcomes are different if they're done in high volume centres than low, and it's quite a common thing in surgery. And we know implicitly for a long time that ECMO falls into that category, that there was also a description of this effect many, many years ago, and that one of the earliest and strongest signals to come out of the ELSO work and early case reports was the difference in outcome from high volume to low volume centres there. And I found it not hard to believe and not surprising in the least that this was all such strong evidence. But despite all this, it's unusual for us to restrict practice of a resuscitation tool in a site and say, no, we have a statewide system that doesn't work. So it's a proper service. You're not interested in the detail, but it was, you know, there was a proper setting up process for it. There was guidelines created, a governance structure put in, and hospitals designated by responsibility. So basically all the hospitals in the state are divided into 4. There's a single comprehensive centre. There are 2 centres that provide intermediate care with cardiothoracic services. They look after their cardiac patients. And there are initiation sites, and additionally, and there are other hospitals we service where we have to go out and pick up patients if they're going to get on ECMO. And that's how we run the state. And VV ECMO is pretty much, because in most years there wouldn't be 30 cases of VV ECMO in Australia outside a pandemic. So putting them across many sites doesn't make a lot of sense. And so the model is that they all come to one centre in Victoria. Now, COVID was a very uncertain time, and I have to share Rodrigo's view that that perhaps across the whole spectrum it wasn't too different to other forms of ARDS, but in the severe cases that we remember, it was completely different. It turned lungs from grapes into sultanas, and it persisted for a very long time. And I put this reference up only to say how grateful we were for the early publication of some outcome and some effects of what we were treating, because there was so much bad press around it, you really didn't know what to do, and uncertainty was driving things. The eligibility chart was just a form of communication we used to classify our patients and to score them, so we would have it would allow us to have some common indications and know how we were including patients to include in our statewide service. So we had accidentally introduced a Victorian ECMO service at about the same time COVID arrived, and so it turned out to have, I believe, a strong effect on what happened to our COVID patients during that time. And we were able to have all referrals funneled through the same selection process, no matter where they were, And so the data I show you is for the whole of the state. There was no cases done outside of this state and represents a whole statewide effect. And I think the hardest part at first was knowing the case selection, because there was lots of bad press about putting people on late for ECMO, but we never really thought it was the patient's fault that their respiratory function got worse at 2 weeks or 3 weeks. And what you can see here is a graph of all the patients from the second wave, the Delta wave, which was much more severe. And this is 54 patients that were put on, classified by on the y-axis by the number of days they were ventilated before they went on, and on the x-axis by their BMI. And you can see it forms this sort of L-shaped relationship. Overall, there was no difference in outcome depending on when you went early or when you went on late for ECMO. Rates of survival were the same. But you can see for the heavier people past a BMI of about 40, they generally got onto their ECMO much sooner. This group perhaps was a bit more severe, the past 2 weeks of mechanical ventilation. Cohorting the way we did demanded that we just create more and more beds as they were required. We couldn't say, so we're full, you'll have to go somewhere else. We did increase to a second hospital to allow some carriage of patients, but we stayed up. But that was very useful in allowing extended support. So we were able to stick this process out, just as Rodrigo said, till it finished without stopping on these patients. And you can see this case of weaned at day 91, 6 months down, again back at work, ambulatory, looks very much like the photo, and that's what the lungs look like at the follow-up. So in total, the Delta wave cases, the 54 from the second wave, sort of came off ECMO according to these charts. So the green are the survivors. And you can see that the average for that group was 41 days of support. It was really long. And what I wanted you to take out of that was once you got to about day 30, most people didn't die. It was just a case of getting to day 30 and then hanging on. And we saw a lot of survivors there. It was something we were able to share with our referring sites as we went through. Our longest case, they're successfully weaned, tracheohooded on and off for another 2 months before dying of septic complications, but it was only 2 patients that died after successful weaning. And so I'm wondering, and comparatively, we have data to suggest that COVID patients fared much better in our state than in other states that went through COVID as they went through. And I was wondering why. And if you allow me to indulge for a moment, I think it's about the emotional context of dealing with these cases. And you can call me crazy. Gail probably will, but I'll do that. And so when you're at this point, when you're at day 33, you've had multiple septic complications, you've got all the organ failures, and then your patient gets bad pancreatitis, it is really easy to pull the pin. It's really easy to say, this case has no future and stop. And I think having a narrower number of providers, in our case 1, helped to get through these phases. And uncertainty is an interesting thing. If you look at the emotions associated with uncertainty, if you present a general context of an uncertainty, say a large exam or an important job interview, these are the primary emotions that are associated with that. And if you frame that same context negatively, that if you don't get this job, your employment prospects might be really difficult in the future, you get the same sort of emotional spread. But if you frame exactly the same question as, this job you'll be great at if you get it, and it could lead to lots of opportunity in the future, the emotional spectrum changes spectacularly. So how you frame an uncertain situation is hugely important. And so midway through the pandemic, when you got lots of patients coming in at a fast rate and you're not sure if you're doing the right thing, these sort of structures made a huge difference. In total, you can see over the 2 6-month busy periods that there was 2,500 ECMO days provided for VV. We're a place that doesn't do much VV. That was a lot. That's about 2 years' work crammed into that time just for the VV cases. And you can see the average length of support there for the 2 periods there. So in total, about 40 days for both. And the successfully weaned rates are on the side. So we were able to maintain the same weaning rates in the Tier 2 site cases as well as the Tier 1 through communication and networking with that. So that was basically all I wanted to say. It was accidental. We didn't build this to deal with COVID. We had built this and then COVID happened, and I think it was a fortuitous event. Thank you.
All right. Next is Ewan Gallagher, and he's going to tell us how we can prepare better to do research for the next pandemic. God knows what that one's going to be like.
Thank you very much, Gail. And thank you to the organizers for the opportunity to speak at this meeting. It's nice to be here in person, talking about pandemics in retrospect, and I guess the future as well. So the question is, what do we need to have in place for the next pandemic? These are my disclosures. So in 8 minutes or less, I want to persuade you that what we need is an engine for discovery. It's networked, it's scalable, it's adaptive, it's transdisciplinary, it's integrated into care, and it's highly collaborative. And I think the good things that happened during COVID illustrated the possibility that this really can happen when we are appropriately motivated and adequately funded. And so I think I want to reflect on some of the lessons of my own experience. So thinking back to the very beginning of the pandemic, it sort of reminds us of that fog of war sensation, the uncertainty that Finn was just talking about. And one of the big questions that confronted the management of COVID-19, of course, was the management of thromboprophylaxis. There appeared to be a very high risk of thrombosis, and the concern was, should these patients be sort of empirically anticoagulated with full dose heparin? And I was involved in leading a global multi-platform trial which examined this question across multiple different states of COVID-19, patients with moderate COVID with higher or lower D-dimer, and patients with severe COVID-19 critically ill in the ICU. And it was, looking back, just a crazy time. Everybody was working so hard on so many different things. And in this trial, we enrolled over 3,000 patients in a space of just over 6 months to answer the question. And we got from the time we got the idea to the first randomization was 6 weeks. So everyone was working so hard, and it seems like, looking back, that these things are sort of hard to imagine now. But we were fortunate to get answers to these questions. But what was critical to the success of the endeavor was first establish global networks. And one of the platforms, REMAP-CAP, was a pre-existing platform trial with a strong and rapidly growing trial network. The ATTACK trial, which was led out of Canada, leveraged an existing network of sites spanning the US, Canada, Brazil, and Mexico. And then the Active 4A platform, which was set up by the NIH, rapidly created a massive network of sites across the United States. But of course, building a network, it takes time. And I think to make a network work really well, it needs to be a formally established one with clear governance, with contracts in place, data sharing, all these kinds of things. So in order to do well, even better in the next pandemic, to answer questions about ECMO, you're going to need to have a network that's well established on formal grounds that can rapidly scale up to answer questions. We need a standardized data collection system. We need well-validated, routine ways of getting good data on patients. Now, I think ELSO, in a lot of ways, is an example to the world about how to do this with the long-standing registry. But this needs to be a data collection system that can collect the kinds of relevant outcomes that we need to do trials in the context of a pandemic. You need a mechanism for what I call smart randomization. So the critical importance of randomization is that it allows you to draw causal inferences about treatment effects in a way that you can't do with other study designs. Despite our best efforts to figure out other ways around it, really ultimately to answer questions about how to treat patients, we need to be able to randomize them. And so having the infrastructure to do randomization is critically important. Now, one of the big challenges with randomization, of course, is having equipoise. And so this is where the idea of smart randomization comes in, so that as a trial accumulates information, it can adapt its randomization distribution so that patients are more likely to be randomized to treatments for which there's emerging evidence within the trial of benefit, so-called response adaptive randomization. And this allows the concept of a clinical trial to be more and more embedded into healthcare, because it ensures that patients are going to be likely getting the treatments that will be good for them, and I think makes patients more comfortable being randomized as well as clinicians. Now, a critical piece of learning well in the context of a pandemic is to be able to rapidly discover. And a general criticism I have of the traditional clinical trial paradigm is I call it basically an active prophecy. You prophesy what you think the treatment effect will be, and most of the time my prophecy was wrong. And then people will make the error of inferring that means there was no treatment effect, which is not the same as finding out that your prophecy was wrong. But in fact, there's a much better way of doing trials, which is to learn as you go using adaptive statistical techniques. And what that allows you to do is to rapidly get information about which treatments are the most promising. You can begin to drop treatments as it becomes clear that they're ineffective or not superior. And so by turning a trial into a process of discovery, you more rapidly inform questions. And COVID really illustrated this because we didn't know what control event rates were. We had no way of guessing really what reasonable treatment effect sizes were. So the adaptive trial approach really came to fruition beautifully during the pandemic. So I want to make an argument that for the next pandemic, we need to have an or multiple adaptive platform trials in place with established networks, with clear governance mechanisms, with standardized data collection systems, a master protocol. And what a platform is basically, like Derek Angus, who was here yesterday, likes to describe, basically you build the stadium, and then instead of playing just one game in the stadium and then taking it down, you keep the stadium up and you play multiple games in the stadium. So the platform is a durable engine for discovery. And one nice approach is actually to embed the platform within a registry, so the data collection is already happening, and now you're randomizing patients within it to discover how to improve care. I want to emphasize, I think a transdisciplinary approach is critical, so collecting biological, physiological endpoints, as well as, of course, what we really ultimately care about, patient-centered outcomes, because the biology and the physiology allows us to make preliminary assessments about whether a treatment's promising or not, and also to identify potentially treatment-responsive subtypes. So with Eddie Fan, we're building an adaptive platform trial in acute hypoxemic respiratory failure, the practical platform randomized trial. And the way the platform's designed is that it's embedded within a pre-existing registry that Eddie's been running for several years now. The platform population is defined across multiple states of severity, so non-intubated patients, intubated patients with different degrees of lung mechanical impairment, and then patients on ECLS. And across these states, we're studying multiple domains of intervention, including a couple of different ECOR trials, as well as different invasive ventilation strategies. And I really think this is the way of the future to make kind of force formal, effective collaboration, because you build the engine and you just let it run, and you can add new questions to it as questions arise. But looking back, I think critically, the key to success is an immensely collaborative spirit. And I think that was one of the amazing things that we all experienced during COVID. It's just the level of collaboration, the way that people put answers to scientific questions before their own career success. And the multi-platform trial that I was involved in really becomes a model for how different platforms can collaborate in real time to answer questions that otherwise would take years to answer. And I think that's one of the great joys of our work, is the privilege of working with other people whom we admire and respect. So thank you very much.
Thanks, Ewan. Our next speaker is Anna Condela. She comes from the University of Washington, and she is actually a CCU intensive care fellow. And she's going to talk to us a bit about equity and access for ECMO.
Thanks for letting me follow this incredible group of presenters to speak briefly on considerations and access of ECMO and equity. I think it'd be hard to fully address this topic in 8 lectures, let alone 8 minutes, but I'm excited for the opportunity to further a conversation about improving and prioritizing equitable access to ECMO. Let's see, this one. Green button. Oh, green button. Great. I have no funding sources or conflicts of interest to disclose. I am grateful for the support of my mentors, including Barclay Stewart, Janelle Bajulak, Nick Johnson, and Andy Lux, who are also my co-authors on our upcoming paper, the themes of which are central to this talk. So prior to the pandemic, I had the opportunity to explore ECMO allocation more through a lens of critical care transport. But in the summer of 2021, the New York Times published an article on VV ECMO and its distribution during the previous year of the pandemic, highlighting its status as a truly scarce resource. This was already striking to me as a physician treating patients on ECMO to see it in a mainstream news source. But it most affected me by reading in print scenarios that I had encountered clinically and my colleagues had encountered, but had little space to reflect on at a systemic level at the time. First was a patient who received VV ECMO only at the, quote, extraordinary advocacy of his family and his professional connections as a police officer. Another described instances of patients who were accepted for ECMO by clinicians but died as the hospital was still evaluating their financial status. Reading this and seeing in real time the day-to-day struggle of ECMO referrals in an overwhelmed system, I found myself thinking more about ECMO allocation through a lens of equity, and ultimately progressed through a few areas of focus in my inquiry. There were, and still are a few peer-reviewed publications to directly relate these, especially in adults, but each question can be placed in the context of existing evidence. So the first was simply, who do we think should receive ECMO and who in practice is referred and accepted for ECMO? And that we have to acknowledge that in a pandemic there cannot be total overlap between these populations. There will be patients who meet clinical criteria for ECMO cannulation, and so any single ECMO center will be forced to make decisions beyond this criteria. That is to say, in a given region, there may be 5 patients in any period of time that meet criteria based on ELSO's guidelines, including age, comorbid conditions, course of illness, et cetera. Even as those guidelines are more restricted in the setting of a pandemic, the region itself may have capacity for maybe 3 of these patients, but if there's no centralized referral system, then one institution with 1 bed might get calls about all 5 of them. In a vacuum, there'd be no significant difference beyond the clinical criteria of the patients who receive the bed and the patients who don't. But in practice, we've all experienced parallel referrals due to the volume of calls and fluctuating capacity of our own institution. There was actually a nice article in the Journal of Critical Care in 2019 from a group from Beth Israel Deaconess that delved into more detail in the scenario of pandemic scarcity of VV ECMO, and acknowledged that a first-come, first-served paradigm would likely in fact lead to disparity between the populations referred and accepted. Unfortunately, the ability to compare eligible patients referred and eligible patients accepted in the setting of a pandemic is very limited. It's challenging to gather data on the patients who never make it past the referral call. So, since there is a population of eligible patients who are not accepted for ECMO in a pandemic setting due to scarcity, excuse me, and our data from the past pandemic is limited, do we have evidence of what non-clinical factors could contribute to disparity between these populations? And here I use the term non-clinical as an imperfect description for factors that are not explicitly included in most criteria for ECMO therapy, but still might influence decisions and of course influence those clinical criteria as well. So there first is just compelling data to show that minoritized patients have worse outcomes from COVID-19, especially early on in the pandemic. And then looking at more specifically resource allocation in other settings, we do have compelling data that in retrospective cohorts, minoritized patients are less likely to be transferred for and to receive aggressive interventional therapy, such as mechanical circulatory support for cardiogenic shock or mechanical thrombectomy for stroke. Then even acting in a vacuum of perfect hypothetical scenarios, there's small observational studies to show that clinicians presented with equal scenarios are going to be less likely to recommend thrombolysis for myocardial infarction and to even refer minoritized patients for heart transplant. Looking at a few other non-clinical factors, we see that there is data to show again, in retrospective data, that in one large transfer system, uninsured patients and women were less likely to be transferred to a larger hospital for treatment of serious diagnoses such as sepsis and chest pain. Women were found to be less likely to receive mechanical circulatory support and acute myocardial infarction. And then in a similar small but thought-provoking study of hypothetical scenarios, physicians were less likely to refer a patient of equal severity to cardiac rehab if that patient was a woman, and also less likely to be aware that they were doing it. So how can we address these systems when building or improving our systems of ECMO allocation? This was a very brief review of some highlights of previous data, and those alone are concerning enough for me to try to pursue some of these tools at our disposal, even if we have to kind of look forward to the next pandemic to study their efficacy. So first, you can consider implicit bias training for staff of ECMO centers. And then we sort of end up in the situation where we both want to blind our referrals to the best of our ability to demographic factors as well as payer status, while still collecting data on that. And this is that really important denominator that our keynote speakers spoke of, so that we can then include that information in our QI efforts, inclusion of race, ethnicity, payer status, other vulnerabilities to bias. And finally, regional collaboration, which is the theme, of course, of this panel in some ways, is to review these ECMO referral processes and, as best we can, target multi-level improvement. And then I'll just say, for a more detailed look at potential multi-level frameworks of studying equity in ECMO, please await our upcoming paper, which will be in ASAIO. And then I'll just finish by acknowledging that the allocation of a scarce resource, as intensive as high stakes as ECMO, will always be prone to inequity. And in some cases, it's hard not to advocate for the ability to consider factors beyond our clinical criteria, such as in the case of Dr. Gutierrez, a patient from that same article who didn't meet criteria and should have been ineligible, but due to the extraordinary advocacy of his colleagues, did get cannulated and ultimately survive. Still, my first concern will always be with the same as the sister of the patient whose extraordinary access ultimately did not lead to his survival. A person shouldn't have to have connections to get equitable access to and treatment with potentially life-saving health care. Thank you. Thanks.
Okay, last but not least, Dr. Matt Payton is going to talk to us about ELSO and pandemics and what we can maybe do better. And then we're going to just pepper these guys with questions for a bit.
Thanks, Gail. The rest of you all were complaining about 8 minutes. Gail told me I have 5, so apologies if I run through these quickly. So we're going to talk about ELSO's roles in future pandemics. I'll tell you, right before the pandemic started, not 2 weeks before the U.S. shut down, many of us were all at SWOC ELSO there in 2020. And just, how much difference a period of 2 years makes. SWOC ELSO conference ended on February 22nd of 2020. At that point, we had 2,600 deaths in the whole world. Fast forward to 2 years later, and you're almost at 6 million. And this is something that all of us have lived through. And I do think it is worth taking a moment just recognizing that and recognizing how severe this was for not only our patients, their families, but also for all of us. This is not the only pandemic that ELSO has been through. And so we had H1N1 and had to deal with that. There was also a much smaller Ebola pandemic or epidemic that occurred, where ELSO was being asked and actually had to put out guidance on whether we would put Ebola patients on ECMO. And so we've had some experience from this before. And we did some things right during this, and we did some things wrong. And I kind of want to go through and highlight those. One of the things we did that I will say in retrospect was absolutely right was the changes we made to the registry. All of us got back from South Africa, and it was actually on the drive home from the airport that we had a conference call saying, what are we going to do about this? And on that conference call, we decided that we needed a real-time registry and needed to create this. And Ryan Barbaro and his colleagues were able to get that up, get that running. We asked all of you to change what you've been doing for 40 years in the way you enter data, and really appreciate that. And as we go forward, that's something we have to do in the future. It was very successful. Within, again, we're talking about from February till September, we were able to, until this first Lancet article was published, we're able to give the world real data, real world data on what COVID and ECMO did together. And we continued to follow that. And because we had this real-time data, almost published a year to the day after that, we were able to actually show changes, show that survival was decreasing in a population of these. And this is one area where I think we did good and did the right thing to say, we're following this. Things are worse than we originally told you. We need to come back and update this. So, that's something that I think was good that came out of this. One thing that is a place where we need to improve in the future is exactly what Ewan was just describing to us. Despite all of what we did, you look at NIH's recommendations for ECMO and COVID that are now, still says insufficient evidence. And they call out specifically that no randomized trial was done. And so using these kind of platform adaptive trials are a way for this next pandemic that we need to be ready to be able to do this. We did move fast, and the reason we moved fast during all of the pandemic was we worked together. Again, you have we left there in February, published in March 20th, not even a month later, about planning and provision of ECMO services around the world. Nothing to me during COVID time represents us working together better than what John Fraser and his colleagues put together with the COVID Consortium. Also, ELSO did what we could in realizing that there was a vast need for ECMO education. Took all the work of the ECMO Ed team together and created a foundational course to train folks to do this. We had our logistics team come together, figure out a way when we were all short of devices and short of equipment, how can we share this stuff together? And then Rodrigo mentioned what they did in Chile. The Parisian teams did the same thing to figure out within a country, how do we standardize things? Because this is really, really important, and Vin mentioned that as well. In America, quite frankly, we did a really lousy job of that. And you saw articles very much like this. And so that's something that US-centric wise also needs to work on for the next one. The other thing is we made mistakes. ELSO's original recommendations were don't start a new ECMO program just to take care of COVID patients. And our colleagues in the Middle East showed us that no, that can actually be done, can be done successfully. We need to, again, be upfront and transparent about this. I work in Atlanta. CDC is literally 2 blocks from where I work. This is what I go by to work every day during the pandemic. And all of those discussions we had this morning about social media and how to deal with that, I think are very applicable to this. That's a place where we can get better. The last thing, there's a bunch of jumbled words up here. These are things that you may or may not see. As ELSO president, I get emails like this to the ELSO office all the time. These are patients, not a psychiatrist, not a psychologist. I read this and I say, this is someone who's hurting. Whether this is depression, PTSD, anxiety, any one of those things, I don't know, I'm not smart enough to know that. But I know this is somebody who's hurting. And we have to figure out better ways to deal with the aftercare for that. And ELSO needs to lead in some recommendations for that. And it's not just our patients. It's all of us in this room, right? We were affected by all of this as well. And what we got out of this and the kind of support we got out of it from the systems we work in probably wasn't effective. It was something more like this, right? So How also can be effective in the next pandemic? I say we're going to learn from the things that we've done, looking in that crystal ball in the future. I think a lot of what these other folks have said helps. We got to prepare for the next pandemic. It is coming. There is no doubt. We got to move fast. We've got to analyze often, admit and correct errors when they do happen. In terms of data, we have a gap here. For the randomized trials, we're going to need complicated data. But there's plenty of other times where simplistic data will actually just be useful for us. We've got to work together, and the patients will always come first when we take care of them. But we also have to remember that our caregivers' outcomes also matter. Thank you very much.
I'm not going to let anybody go yet because there's still 2 minutes. Okay, maybe more. Well, we're going to bring the panel up because actually, to be completely honest, we started 10 minutes late, so I got 12 minutes to say the truth. So, does anyone have a question for this great group of people? First of all, I want to thank you all for sticking to your time. You guys are amazing. It's great. So here's a question. Perfect.
If it's okay to ask, Matt, what did you do about that email, about those emails? Have you responded to them?
Yeah, so first comment I would make about that is that email is not exactly as I got it. I, of course, obfuscated things appropriately. So that particular patient, yes, we actually did reach out to that particular patient. I don't think is going too far with confidentiality here, but actually lives in the same city that I do. Randomly, and they had just reached out to the ECMO office. With that being said, the patient never responded and never reached out. It's probably not 5 a week, but it's those kind of emails are not uncommon at all of folks reaching out for help. That's a place where I think ELSO will never be involved in the organization in direct patient care, but that's something we have to find a way to be able to help and support those folks and get them to the care that they can.
So I actually have a completely, a little bit of a biased question because we're struggling with it so significantly in our institution, but I think all of you work in critical care and it's across the world, and what I'm hearing from everybody, it's the same. But what could we have done, or could we have done anything, or could we have anticipated? Maybe we should have done research on this as well. We are all short of caregiver resources to the extent that even within my own province, we have 89 pediatric ICU beds, and the other ICUs close, or they close 2 beds. And we have no nursing resources, but we keep taking patients because where are you going to put this sick child for us? And, you know, some of the most amazing people that I've worked with, nursing staff, mid-level, are now gone. They're tired. They're exhausted. We put them through a lot, I think. But is that true? Or was it going to happen anyway? And I guess, like, how do each of you deal with that? How do you advocate for that, right? We have a panel of physicians. I'm a physician. But what about, how do we advocate for, how can we change that? Do we have the power to? Any one of you can start.
All right.
They're all bumping each other.
I forgot to step backwards. Look, I think we learnt some valuable things under that staffing pressure, and it reinforced a model sort of we've had since we brought ECMO care into the scope of practice of our nurses, is that when you elevate people to the task, they're always up to it. When you tell people they're not qualified to do something, I think it's a really bad model. And one of the things we did was change the nursing model during COVID so that non-accredited nurses now provided the care with support. And it's something we'd do again, actually. And I could be completely wrong. People might want to come up and correct me, but I don't think it generated animosity. I think they were glad to be asked to do it, from the ECMO side. The general exhaustion, advocacy, existential dilemmas, I've got no idea about that. I suffer them myself, actually. Yeah.
And I think there was a huge emotional toll probably on them. They're the ones that are sitting 12 hours a day at a bedside, holding an iPad, walking through things with the family. It isn't that we don't do work as the physicians, but they're there, that one-on-one with a family and trying to figure out how they're going to get them through it. Anyone else have a comment?
I guess the comment that I would make is you're absolutely right. We need to study this. We need to look at it, because while the COVID patients may be gone, the effect that has had is on the caregivers is going to impact healthcare for the next 5 to 10 years. I think all of us are in scenarios where the units we work in are, most of the senior staff are gone. And we've got a whole new set of folks to train. And that's going to take a while. And so, but the other part I look at that is, that's a real opportunity here, because we've got a whole new group of people to train. We've got people that we can teach new and modern medicine to. Some of those things that we've always wanted to do, but have been held back by culture, by history, by things, those are places where we've got opportunity to make change and be able to deliver better care. We'll be better from it in the long term, but it's going to take a while. It's going to take a few years to get there.
How many are feeling the resource scarcity issue? Everybody. There you go.
Jim was sitting back there. Raise your hand.
One more question. Or go ahead, Ewan. Speak.
Well, I was just, I've been reflecting on this challenge also from the standpoint of research, because I think one of the things that seemed to work well in certain places, and we all think of the UK recovery trial as a prime example of where, simple and very pragmatic trials could be executed by frontline healthcare staff. So that just sort of became part of their job description to do the recruitment and randomization, data collection. It had to be very pragmatic and focused, but it was possible. And that was one of the reasons recovery was so successful, because they really embedded that research into clinical care. And so to pick up on what Matt was just saying, there is an opportunity as well to help people see research as part of the role of a clinician. Traditionally, we've had these very siloed worlds, and if we found a way to integrate them a bit more as part of that, culture improvement and culture shift, I think that's an opportunity as well. The problem, of course, is that this is all happening in the context of scarcity of resources, with people already burnt out or close to being burnt out. So how do you sort of add to the list of things they're supposed to do? So I think that presents a real challenge, but hopefully as the system catches up, as new people come in, we're able to increasingly sort of merge these worlds together to better embed research and care, because most of the patients we look after never end up in a trial, and there's so many missed opportunities, I think. And that's bad for patients. So.
Agreed. Is anyone else? Go ahead. Yeah, sure. Go ahead, Rodrigo.
I would suggest you read a paper published by Leonardo Salazar. He has the busiest program in Latin America. The resources are scarce there. And they increased their ECMO availability from 10 patients to, I think, 40. And the mortality in initial patients, in the first 60 patients, was 74%. And he was desperate. I mean, we talked each other, and he decided to stop. To stop for weeks, retrain the people, retrain more people, and modify, for example, how you wash your hands. Things that simple, but very important. And they decreased the mortality with this bundle of care to 36%. So the lesson of that article, and I really recommend it, is that if things are really crazy and things are going really bad, you have to stop and rethink and ask for help. And that's something pandemia gave us too.
Thank you. Go ahead.
It's maybe a strange question, but we are a group of people that all work around a very high demanding tool in high income area, generally speaking. This virus was a respiratory virus, and that's why we are so touched about it. The next pandemic may be completely different. So maybe a GI stuff or something else that will require different tools to be managed, and that may affect other people in the world. And that may not come tomorrow either, because we are really active about speaking about all of this, because it's nearly not done, or maybe we think it's getting better. It's just, what I'm afraid is that we think we got lessons because we were really prime hands-on to this, and we think about that. But we may not be the ones that will have to deal with the next one. So how, in a way, I guess, how can we help global healthcare people remember that it may happen again, but with another virus touching other people, and such that the lessons we draw from this one could be applied for another one in the future, should that happen in 10 years or 15. It's easy to be COVID boosted now, because it's just like we all still some sort of into it, and especially like transplant people, we're seeing the aftermath of it. But the next one may be completely different. So as a society that was prime hands on this disease, it would maybe be good to, I don't know how, alert or make sure that others keep being on their toes, because it may require the exact same tools for another type of disease that we won't have to deal with. ECMO may not be the answer to the next disaster.
Perfect panel to answer it.
ECMO is always the answer.
If nothing else, it buys you time to think and time to figure out something to get the patient better. But in all seriousness, you bring up a very good question. And so, again, one of the advantages I have in working in a place where, because CDC is literally right down the road from me, more than half of my infectious disease staff are CDC trained or CDC folks. This is something that we think about all the time, and is something that we think about because, yes, we know flu, we know respiratory diseases, but we also do think about emerging infectious diseases. I don't, if your diarrhea case is one, that's fine. Quite honestly, what scares me a lot more than that would be a meningitis kind of thing. And so what we have now is not perfect, but we can take pieces of what we've learned from this and be able to apply them to other scenarios. For example, again, because CDC's down the street from me, we have a whole full isolation unit where we take care of Ebola patients, where we take care of the weirdest of the weird kind of viral things. And that's part of what we do. And so we have a whole training system of how do you train people to do that? And how do you ramp that up? And there are some of these things that are out there and that folks are working on. ELSO has to partner with folks who are doing that because, as you mentioned, ELSO is not going to cure, and ECMO is not going to cure the next diarrheal virus, right? But for the ones that are the myocarditis, for the ones that cause bad lung injury, that's where we need to be involved and work with them. I'm speaking of this very North American centric right now of CDC. I'm doing that because that's what I see every day. But it's not just that. It's working with WHO. It's working with other leaders around NGOs around the world to try and help with this. So your question is a very good one. It's just a very difficult one to answer.
Rodrigo?
Yeah, this is just a personal view, but I think we have a pandemic already going since many years ago that is cardiovascular disease. And if you think that 7% of the MIs do cardiogenic shock, and 45% of those patients die, you had a window of indication of mechanical support, and ECMO is within that possibility. So we are in debt about that. I mean, I'm very sure that when cardiologists realize that, they're gonna take over ECMO, but definitely there is something there that we're not looking at. We're looking at, but at the same time, we haven't really faced, I think.
And just to add to that, again, I'm a pediatric doctor. I put more kids on ECMO during COVID for heart disease than I did lung disease, right? For us, it was MISC-C and fulminant heart failure. That's what got our patients on. And so, again, I'm going to draw very different things from this than perhaps you would.
So I think the sort of learning points from that last question is that we have something that we have to be able to bring forward in 20 years when I'm retired or dead, one or the other. And, all the newbies need to sort of deal with the next one. I don't think any of us thought that we would live through a pandemic like we did. And we're still not out of the woods. There are many things that we learned even within our own institution, like actually wearing a mask and face shield when you're intubating a patient. Wow. It was one of the things that we were supposed to be doing, but we didn't always do it. And so regrouping and learning those things and sustaining that type of proper care is really the most important thing now, and then hopefully reaccumulating our health resources. But I want to thank everyone for staying who stayed, and I want to we should give these guys a great round of applause. They did a fantastic job. Thank you. And apparently there's alcohol on the lower floor, so off you go.